So our next speaker is Dr. Sidney Hankerson, who's the Director of Mental Health Equity Research at the Icahn School of Medicine. Sidney, we'll turn it over to you.
Wonderful. Thank you so much, Linda, for that warm introduction. Good evening, everyone. I will go ahead and share my screen. Okay. I'm really honored to be able to present, so I'll just move forward. My talk is broken into three main sections. First, I'll briefly go over some of the disparities in treatment with a focus on access to antipsychotic medications, on some of the structural issues that contribute to those disparities. Next, I'll introduce principles of community-engaged research. And then lastly, talk about how we at Mount Sinai recently submitted a proposal to implement or leverage principles of community engagement, specifically for young adults with first episode psychosis. So there are significant racial disparities and treatment inequities as it relates to schizophrenia. And so my focus today is going to be among African Americans. There are actually, this is well documented in terms of access to treatment. Certainly in the landmark NIH RAISE study, there was actually disparities in treatment, as well as disparities in access to family psychoeducation among Black Americans. And these treatment inequities are really linked to the downstream effects of structural racism. Dr. Camara Jones, in her landmark paper, really conceptualized or defined three levels of structural racism. And I recently published a paper in JAMA Psychiatry applying some of those principles clinically and to research. So briefly, the three levels of racism are structural or institutionalized, which contributes to inequitable access to education, housing, healthcare, which is certainly the focus this evening, and the criminal justice system. We certainly know that people with schizophrenia have high rates of involvement with the criminal justice system. After the structural level is actually individual levels of racism, which is defined as prejudice, discrimination, or microaggressions, which are the subtle insults that one person does to another based on their race. And then the last level is internalized racism, which actually is the impact on people who are subject to structural barriers and structural racism, and the self-doubt, hopelessness, and racialized inferiority that people in subject to these structures face. I think it's critical to talk about the structural issues at play, especially as we think about our patients and our families with schizophrenia, because many of them are subject to these because of their racial or ethnic background, but also because of having a severe mental illness. Some people would say that they have, as it relates to stigma, kind of double stigma. And so these structural issues are compounded with people with schizophrenia. And especially in the African American community, there is a history of cultural distrust of antipsychotic medication. This is a image from Dr. Jonathan Metzl's book called Protest Psychosis, from a medical journal in the 1970s, where you see this tagline, assaultive and belligerent, and then an Afrocentric looking man who looks strikingly like James Brown. And so you have this image of this, Afrocentric looking man, and then of course the advertisement for Haldol. And so it's certainly been established in the literature that African Americans with psychotic symptoms are more likely diagnosed with schizophrenia compared to white men with the very same psychotic symptoms, who are more likely to be diagnosed with bipolar disorder with psychotic features or major depression with psychotic features. And so these diagnoses obviously have treatment implications and can contribute to overutilization of antipsychotic medications among African Americans. And so this is some of the challenges as we think about engaging communities of color in mental health care generally, and in psychiatric antipsychotic medication treatment specifically. And so the good news is that, community engagement can really address some of the structural issues that impede the utilization of antipsychotic medications. Community engagement, I'm defining it as Martinez did in a recent paper, as the process of working collaboratively with and through groups of people affiliated by various similarities, whether that's geographic proximity, special interest, or similar situations, to address issues affecting the well-being of those people. And so as we think about community engaged research, there are two central principles of community engaged research. First is that it requires equitable partnerships between community members and academicians. And second is that it links scientific inquiry with health policy, because we know health policy ultimately, drives the change that can impact some of the structures that contribute to inequities in treatment, and hopefully will lead to better treatment and clinical outcomes for our patients. And so community engaged research and community engagement really promotes the uptake of multi-level interventions. Certainly at the individual level, we're focusing this evening on the provision and uptake of antipsychotic medications. Also focus on the interpersonal level, or the family, and how community engagement can promote the uptake of evidence-based programs for family members. Then also thinking about how the community can be impacted by these interventions, and then also thinking about policy. So these are kind of looking at a social ecological framework, or how community engaged interventions can promote the uptake of multi-level interventions. And in the literature, there is a host of different community engaged research methods. Some people may have heard of action research, participatory action research, community-based participatory research. I'm going to be focusing on community-partnered participatory research as one of the methods of community-engaged research. Community-partnered participatory research is an evidence-based, manualized model of community engagement that was developed specifically for mental health services research. It was developed by Dr. Ken Wells and the late Dr. Loretta Jones. Ken Wells is at UCLA, a psychiatrist. Loretta Jones was a community advocate and received her doctorate, but they worked together as academician and community partner to really focus on community partnered participatory research. And this research approach really emphasizes the partnership aspect between community members and academicians.
We apologize for the technological difficulties. So we talked about the vision. The Valley is the second step of a community partnered initiative. And that's where you basically work in partnership with community members to implement evidence-based practices, to implement protocols to administer antipsychotic medications. And then the third step would be the victory. That's where academicians and community members come together to celebrate, share lessons learned, and then recast their vision based on what they experienced in the vision in the Valley. So it's really kind of a plan, do, study act kind of iterative process. So next slide. So you can see in this slide kind of community partnered participatory research really has four key principles. Is two-way power sharing. So really making sure that there is equitable access and distribution of resources from academics to community partners. Community empowerment ultimately is a key principle also. And then equality and respect for diversity. One of the benefits, of this particular approach is that it has been shown in multiple randomized controlled trials to actually increase participation of people of color in research studies, actually increase trust in the research process, increase capacity of community-based organizations, as well as providers and their own ability to provide culturally sensitive care. Importantly, it's been shown to reduce disparities in treatment outcomes. Next slide. So the next slide you see actually the Community Coalition logo that I used using a community partner participatory framework to create a community coalition or an advisory board for research studies that we conduct in Harlem and New York City. The coalition is composed of, academicians, clinicians, community members with lived experience with mental health conditions, policymakers, and clergy, because a lot of my work is really conducted in partnership with faith-based organizations. And our coalition has really focused on reducing stigma, which is especially pertinent as we think about the provision of antipsychotic medications, building community and academic partnerships, and then encouraging help seeking for mental disorders. Next slide. This is just an image of our coalition. It was taken several years ago. You know that because I still had hair. But this was actually a picture when we came together and officially signed partnership agreements to become a coalition. And I really am proud of how diverse our coalition is in terms of racial and ethnic background, in terms of gender, in terms of age, and in terms of the stakeholders that are represented. It's really multidisciplinary. Next slide. And so in terms of the impact of the coalition, the coalition has really transformed the way that we've done research. We hosted a community symposium to increase awareness about mental health and reduce stigma. It drew over 400 residents and was also a good way to recruit people to participate in the coalition. It expanded the focus of my care award. We transitioned the actual intervention from training clergy to training people in mental health first aid, which is an evidence-based mental health literacy intervention. And then we tailored my current R1 a recruitment video in a cluster randomized controlled trial focused on depression. And this video is being disseminated in church study sites. Next slide. So I'm going to skip the next slide in the interest of time. It was the actual video, but in the interest of time, we'll just go to the next slide. So the next slide just really highlights the diversity of research studies that I'm employing this kind of community partnered model, as well as the different psychiatric conditions that are using principles of community engagement. So I actively have NIMH R1 focused on depression, R1 from NIMHD, actually focused on increasing colorectal cancer screening, and then R34 from NIDA, which is focused on reducing opioid overdose. We recently got a grant funded from the American Foundation for Suicide Prevention to prevent suicide in Black youth. And I also have worked with the New York State Office of Mental Health that is using this community engagement model in its efforts to reduce stigma across New York State. Next slide. And so the last part we'll talk about today before opening it up for any questions people may have is specifically how to potentially, leverage these community engagement principles in schizophrenia treatment. So we recently, applied for a grant, and we'll find out in the coming weeks whether or not it's funded, to apply principles of community engagement to a trial of first episode, psychosis. Participants in this trial will be young, mostly Black and Latinx men. And we know that this is a hard to reach group. We know that these participants are more likely to be involuntarily committed for treatment, have increased incidence of EPS, and understandably have kind of earned skepticism of research from these participants as well as from their families. Next slide. So we propose to engage several groups of partners, in this trial, patients with lived experience with psychosis, family members of people with schizophrenia, clinicians and researchers, and then advocates, leaders from NAMI. Next slide. And so we've divided this community engaged process by creating 4 work groups. So these work groups, each of the work groups will have patients, family members, clinicians, researchers, and then advocates. And so the way that we've proposed to structure, our advisory board for this study is that this advisory board will meet biweekly for the first 6 months and bi-monthly thereafter. And in the patient-reported outcomes work group, the focus of this work group is really to garner information that is going to inform the study outcomes. So the work group will really to help structure and analyze interviews with patients, clinicians, and caregivers. It will help the staff conduct literature reviews, identify patient-centered and relevant clinical outcomes. We'll be reaching out through kind of members networks. And then really the focus of the partners is to partner with researchers to prioritize these outcomes. Next slide. So the recruitment work group is really focused on developing culturally sensitive outreach materials that help consent and share study findings with our patients, with a specific focus looking at the intersection of race, gender, and schizophrenia research, and of course, taking into account antipsychotic medication side effects. The communication work group is really charged with, developing culturally tailored educational materials to increase awareness about the study. It will be integrating, content and principles from these 2 evidence-based, kind of psychoeducation programs, mental health first aid and NAMI's family-to-family program. And then the dissemination work group will really determine how to communicate project findings to patients and family members in meaningful and understandable ways, really promoting co-authorship, co-presentations, disseminating our findings in novel settings and not just in academic settings, like through churches, and then having kind of legislative breakfasts with policymakers to begin to share some of the outcomes of this study in a way to try to transform policy. So in summary, first, I want to say thank you all for your patience and your grace because of my unstable Wi-Fi. But I think there are 2 key points, from this talk. First is I think that community engaged resource really promotes the use of multi-level interventions that promote and support patients and families. And I think that it may be especially useful for groups that have traditionally been underrepresented in research, especially in medication treatment trials. So thank you.
Thank you very much, Sidney. That was fantastic. Thank you for the presentation. I'm sure that people have questions, and I had one. I think I might have missed, but one of the 4 work groups you were talking about was prioritizing outcomes, and I missed what you said about that one. If you don't mind expanding or repeating, whichever it is. Thank you.
Sure. So I think, so that would be the patient-centered, outcome work group. We have certainly our standard battery of outcome measures that we propose, in the project, and using principles of community engagement, we would basically lay bare all of those outcome measures to our advisory board, get their thoughts, help us to think through what orders the questions should be put in, making sure that if any, adaptations to account for literacy levels would be made, and then potentially to generate new questions that we have not thought about or that are not captured in kind of standardized batteries. So that's the job of the patient-reported outcome measures work group.
Great, thank you very much. Yeah, that sounds very important. Open it up for questions for Sidney. Jerome.
Hi, Sidney. Great presentation. I just am curious about I know you've done lots of research, or I'm aware of your research in Black churches. And the Black church is really, at least in my experience, a cultural organization and more than just a religious organization. You mentioned kind of gender and race is kind of issues to consider. I am wondering how, and I think there's a stereotype of Black churches, which I think is often inaccurate, but not always. That kind of, there's a resistance to LGBT folks, so how to partner with religious organizations in a way that can take the strength from the religious organization without being exclusive to other folks in service of improving research generalizability.
Yeah, no, that's a great question. And to be, transparent, I think there's certainly in our research experience and certainly in the literature, there is a history of religious organizations being harmful towards people who identify as LGBTQ, and certainly harmful towards folks with psychotic disorders. In our studies, when we looked at levels of stigma between depression and schizophrenia, stigma after mental health first aid training for depression decreased. Stigma for using a vignette with someone with psychotic symptoms did not. And so a tremendous amount of work needs to be done. I think a lot of psychoeducation needs to be done, around engaging, churches around folks with schizophrenia. And so we've worked with NAMI to try to implement more family-to-family programs and more psychoeducation into these settings. And we've really been very transparent to our coalition to say, and to assess the pastor's comfort in engaging people with schizophrenia. And we quite frankly have not engaged houses of worship that either directly from the pastor or based on, anecdotal experience from our coalition members have been harmful towards people with psychotic disorders. So that's the way that we've done it.
Got it. Thank you. So choosing partners wisely, it sounds like.
Yes.
Thoughtfully. Thank you, Sidney.
And realizing that not every potential partner is right, for this work.
Thanks.
Thank you very much, Sidney. That was really a fabulous presentation, and it's certainly very important issues. So thank you for sharing that with all of us.